This next section talks about continuum of care. When we talk about residential and institutional care, the most often cited reason for supporting a restrictive setting is to protect the child and the community. In other words, if the child's behavior is terrible, the only thing that works is group or resident or institutional care. The research does not support this. The research is, and there's been research on this for at least 25 years that I know of, when children were either placed in a group or institutional care or into a well-supported foster home and placed blindly regardless of severity. In other words, there were as many severe kids in foster care as there were in group home or institutional care. Some of you might be saying, that was a pretty dangerous piece of research. And I guess if you don't know the literature, it would have been dangerous, but if you know the literature, it made complete sense. What were the outcomes? The outcomes were as predicted. Those very difficult children in foster care did far better. They succeeded far better in school. They committed less crime. They committed less crime after the placement, and they were able to function far better in their families. In other words, the oldest of old solutions, put the child in with the family, support the family well, turned out to in fact be good for the sickest kids as well as the not so sick kids. The old idea, therefore, that you have foster homes for the okay kids, group homes for the more severe kids, and institutional care for the sickest of the children simply does not hold up. What we need to do is we need to start thinking about a new continuum of care. What I'd like to address is where the thinking is at the current time. The thinking, I'm saying, in terms of the people who have studied this the most. If we were to trace out a continuum of care, we would start off at the very beginning with a pre-placement intervention called family conferencing. It's probably been made famous by interventionists in New Zealand, and certainly it harkens back to more work that was done in Hawaii and work that's been done in a number of other locales, and the work that I've done myself in some of the First Nation communities here. In other words, you simply bring every family member that you can find, you bring them into one place, and over a day or two, you do problem solving, you do decision making. And one of the big decisions to come up with and to have is where the child will live. This kind of family conferencing is part one of the continuum, the beginning of the continuum. Then, from that point, a number of good options follow. Either A, temporary placement with a family member, or B, a temporary placement in a foster home that is hopefully representative of some of the more modern approaches to fostering, or C, adoption, or D, intra-family or internal family adoption. Those would be the first interventions to put in place. From that comes the possibility for more developed, more involved fostering arrangements. Fostering arrangements that, for example, may include a respite center, a place where the child can be sent for 1 or 2 days max to calm down over a difficult period in the family and then reintroduced. And for the foster parents to have access, very liberal access, and hereby I mean daily access, to psychologists, social workers, and community support workers who are able to team with them in order to advance the treatment for this youth. And most important of all, for this fostering family to really have a true leadership role within the overall care team. The question comes, well, what about the kids that are way too sick for these interventions? I am here to tell you there are remarkably few of them. That our group homes and institutions are filled with kids who do not need to be there. I did one reading of a group in Finland who said that within Finland there were maybe 40, 50 kids, and that were requiring things beyond a well-supported wraparound fostering or multidimensional treatment fostering approach. There are for sure very few kids that need other levels of care, and even for those children sometimes community options can be developed. What is remarkable, however, is how many options can be generated when you have a staff that is trained and used to working in the community. You have to develop this staff. Finally, what I'd like to strongly impress upon a listener is that in treating behaviorally disordered children and youth, you have to have the smarts up front. By that I mean you have to have the smartest interventionists, your psychologists, your psychiatrists, your social workers, right up front with the foster parents, working with the children daily and weekly to make sure that the systems of care work. It is no longer defendable to take psychiatrists and social workers, put them in a hospital, and have them work only there. There is simply no research to support that approach, and in fact there's a lot of research that supports the idea that that should be discontinued. The purpose of these videos was to help the general public, policymakers and interventionists come to grips with the fact that we need to modernize our system. We cannot continue to have this massive use of group homes and institutional care that we're seeing in this country and in other countries. We have to modernize the system. Modernizing the system means giving up the old continuum of care and moving towards the new one that is based on maximizing the use of the community and the family environment in order to advance the development of these children. Thank you very much.